Good afternoon, everyone, and welcome. My name is Kelsey Goforth, and I am Dying with Dignity Canada's Director of Programs. Today, I'm joined by my colleague, Amanda. We would like to begin today by acknowledging that the land on which we gather here today is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement. Today, Toronto is covered under Treaty Number 13 and the Williams Treaties. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibilities as treaty people to engage in a continuous process of truth and reconciliation with all peoples across this land. I am thrilled to welcome you today and want to remind you that through our webinars, we aim to provide you with information and key takeaways, as well as create a space for conversation on end-of-life topics alongside the professionals that know it best. Before I welcome today's speakers, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the end. Please try to keep your question as concise and clear as possible. While we are going to try to get to as many questions as we can today, we might not get to everybody. So if you do have an outstanding question or question that's more personal in nature, please email us at support@dyingwithdignity.ca and we will follow up with you there. The session will also be recorded. We're also going to be sending out a post-webinar survey today that's going to pop up on your screen after we wrap up this afternoon, and that gives you the opportunity to share your feedback with us. We're also accepting registration for an upcoming series of our Death Dialogues program. So if you're interested in that, there's going to be the opportunity to sign up through the post-webinar survey there as well. Now to introduce today's speakers. We have with us today Dr. Sarah Gower. For over 20 years, Dr. Sarah Gower has been practicing comprehensive family medicine that includes office care, full spectrum palliative care, obstetrics, and inpatient care. Initially working in many small communities across northern and rural Ontario, she also spent time teaching at Queen's University before starting her practice in Elora, Ontario in 2009. She was chosen as one of 7 Ontario College Regional Family Physicians of the Year in 2021 and is an associate clinical professor with the McMaster Department of Family Medicine. Most recently, she is co-chair of the board of directors of the inaugural Aboyne Rural Hospice, a long-term passion project to bring hospice care, including MAID, to her rural community. Dr. Lindsay Campbell is a family physician working in a remote community in the Yukon called Watson Lake. She first became interested in palliative care during medical school while doing an elective in Cape Breton Island. Her integrated family medicine residency program allowed for her to do weekly home palliative visits throughout her first year. Soon after graduating, she started working in the Westview Hospice and as a hospitalist, then later joined the Northern Alberta MAID team. She continues to provide both in-hospital and at-home palliative care and MAID in the Yukon. Thank you so much, both of you, for joining us today, and I'm going to pass it on to Amanda to get us started.
Thank you so much, Kelsey, and welcome to Sarah and Lindsay, and thank you both so much for joining us.
Thank you for having us.
Yeah, thanks for having us.
Of course. All right, so let's go ahead and get started in the introduction. And so I'll pose this question first to Sarah. Can you tell us a little bit about why you decided to enter medicine and which communities you've served in as a healthcare provider?
Sure. So I grew up in a very small town in Ontario, just south of Owen Sound, and knew that I wanted to live in a rural area eventually. And so through various non-medicine related paths, eventually found my way back to it. And then did my residency up north in Northern Ontario. So spent quite a bit of time in rural and remote areas there. And then ended up down in my town in Elora, where I do work at our local hospital and get to sort of do all the parts of medicine that I like, which includes a lot of palliative care.
Thank you. And as a follow-up question before we move to Lindsay, of the communities that you've served in or that you've worked in rather, have you noticed any distinctions between each community?
Yeah, so I've mostly worked in Ontario, lots of everywhere Sudbury, Thunder Bay, but then also in between Marathon, Atikokan, Dryden, lots of small Manitoulin Island, and then some smaller places in southern Ontario as well, Kincardine, Goderich, Exeter. And the northern communities are definitely less resourced, especially at the times that I was up there. But it's, every one thing about the town I'm in right now is that a lot of people are moving to it. It's not a town where people are leaving, which was the case in some of the smaller northern communities we worked in. And some of those towns are now like a town like Marathon is actually growing quite a bit now. People are moving back in, but it's much more dependent on what the local employment is and resources that way, whether people are generally moving in or out. And then, yeah, so there's a lot of, I think, the major differences I would say would be between the higher level of resources and availability of stuff in southern Ontario versus northern and more remote places.
Right, thank you. And same question posed to you, Lindsay. Can you tell us a little bit about why you decided to enter medicine and which communities you've served in as a healthcare provider?
Yeah, I was just sorry, I apologize. I'm just recovering from laryngitis, so I don't normally sound like I smoked a whole pack today. Um, so I was originally just drawn to the kind of the longitudinal ability to follow your patients through life, kind of cradle to grave medicine. I had a wonderful family doctor, also grew up in a rural area, knew I wanted to practice in a similar way. And so I did my training all in Alberta. I did an integrated clerkship out of Sylvan Lake and Red Deer, and then did my residency in a longitudinal program in Stony Plain and Spruce Grove, which is kind of like a suburban area, and then Westlock, it's about an hour north of Edmonton. And I, when I graduated, practiced between those two sites, going back and forth, and then actually came up to the Yukon. I first did 2 locums at a Whitehorse, kind of 2 years in a row, and then started in Watson Lake in, I think 2015. I started locuming in Watson Lake, where I am now. And my husband and I moved up here. We're both family physicians during COVID, actually during May of 2020. We've been here full time since.
Wow. And same follow-up question as well. Are there any distinctions that you've noticed between each community that you've served?
It's very, very different, especially it's changed a lot in the 10 years I've been in practice. But Stony Plain and Spruce Grove is as it's a suburban site of the Edmonton Health District. So it had a lot more resources than other places that I've worked. Westlock is only an hour north of the city, but yet has very different resources available, not the same level of specialty care. Whitehorse is all mostly family doctor run. We do have specialists there. We do have 2 trained palliative care specialists. It's not a tertiary hospital though. And where I am in Watson Lake, it's a whole new world here. I really had to learn to rely on physical exam skills, because when I came here, it's very limited resources that we have available, including basic testing even. Our lab results and everything get sent out, sometimes can take 5 days and stuff. So it's very, very different populations in each area too. So yeah.
All right, thank you both. We're going to move on and ask about some of the barriers and challenges as you both kind of referenced here with the different communities that you've served in. And we're going to focus specifically on healthcare access. So we'll start with Sarah this time. I'd like to ask, what are some of the challenges to healthcare access that rural patients face in general?
So, I think it is, there's definitely can be a major lack of primary care, so of family physicians or nurse practitioners. Cities may think that they're under-resourced, but really when you look at the numbers and the availability, there is definitely a significant difference in what's available per capita in rural and remote communities across the whole country, really. There's no real area that's doing great right now. And then in terms of if you are able to access primary care, then your access to specialty care is also very, very different than what you would be able to access in a city. Now, having said that, a lot of us who work in rural areas are used to working at a higher, what we call sort of the higher bracket of our skill sets. So maybe there's things that I do that I might just take off that skin lesion or have a go at injecting something or aspirating something or whatever it is, or figure it out, where my colleague in the city might tend to refer that, and you would have to wait for a specialist specialists to do those things that I just kind of wing a little bit. I mean, we're very good at winging it, don't get me wrong, but I think we practice higher to the level of our skills than some others might in bigger areas. But there's definitely, and certainly for people who are critically ill or who require high levels of care, it can be very difficult and challenging for us to access that care that in a city you would just walk into any hospital and be able to access those people very quickly. And that goes across palliative care, obstetrical care, geriatric care, surgical care. It really hits all areas. And we're really experiencing that in ways that are worse in the system right now than I've actually seen in my practice lifetime.
Wow, thank you for that. And as a follow-up, with your experience in Elora, Ontario, is there any other challenges that are unique to that community that you'd like to share, or is it sort of the same experience otherwise?
Well, we're probably a bit luckier just because geographically we're more closely embedded in Southern Ontario and there's some quite good systems in place, and some people generally are a little better resourced than they might be in more remote areas or in lower income areas in general. But certainly, there's no public transit. You can't just kind of hop on a bus and figure out how to get to somebody. You have to rely on driving or on your friends and neighbors to get you around. There isn't a lot of social housing that's available. Those sort of supports are really lacking. That's probably what we notice the most in, I think, any rural community in the province.
All right, thank you. Lindsay, same question to you. What are some of the challenges to healthcare access that rural patients face in general?
Especially for us in a remote community, it's just distance is a huge deal. So even to get a CT scan or see a specialist, patients have to drive 5 hours to get to a hospital. That includes taking time off work. And it's financially difficult for a lot of people to get the access to even to get the basic workup that they need. In essence, that's a huge difference. A lot of our stuff that can't be done in Whitehorse includes sending people all the way to Vancouver to get it. And so that's, and it's expensive. It's like $400 a night for a hotel room in Vancouver. And the Yukon government is great. They do provide subsidies, but it doesn't cover the cost of that. So accessing basic health resources that people have at home for the majority of the country is a really big deal in the Yukon for a lot of people. And some people just choose not to do it because of the inconvenience, or if they have family members they need to care for, etc. So that is a huge one. A basic what we can offer here, we're limited by our resources, and like Dr. Gower said, we do what we can. We wing it sometimes, and it's really increased our skill set to be able to offer everything that we can here in people's homes for them. So that's one of the biggest things, and I agree with everything that Dr. Gower said as well.
Yeah, thank you. It sounds like there's quite a lot of versatility that's sort of acted upon in both of your practices, and to try and maximize the time that you spend with the patient to give them the absolute best care that they can. So thank you for that. Let's go to next question. We'll start with Lindsay this time, being cognizant of your laryngitis here. For this question, if someone in your community does not have access to a family physician or a nurse practitioner, where could they turn to?
Well, I have to say that we are incredibly fortunate in our community to have probably the best access to family medicine in the country, I would even say. So we have 4 full-time docs at all times for a population of 1,000 right in the town, and a catchment of about 2,000 to 3,000 in the entire area. So we are incredibly well resourced in my immediate community. That being said, the rest of the Yukon is not the same. Whitehorse is definitely under the national average. So it's very difficult. Whitehorse just opened a walk-in clinic to be available. And before that, it was the emergency department was being used as for the access, unfortunately. So it was really long wait times and really high volumes of patients coming through there. In our community specifically, we have 3 docs working in clinic at all times and 1 in the emergency department. So patients are used to getting same-day access as they need it. And I don't think they realize what it's like sometimes in the rest of the country, that if patients do have to wait, sometimes it's maybe 1 week access, but they have to wait for a specific doc they want to see. There's some complaints that our receptionist deals with, but we are very, very fortunate to have wonderful access.
Wonderful. All right, same question for you, Sarah. If someone in your community does not have access to a family physician or nurse practitioner, where could they turn to?
Yeah, so it's really interesting that that was Lindsay's answer because it's actually kind of my answer too. And even though, I think in rural areas in Ontario, we've been so used to managing all of our patients. Like because we know they don't have a lot of other places to go. We know that they can't just go to the walk-in on the corner because there isn't one. Or maybe like we do run a walk-in and after hours clinic, but it's us, like it's exact same physicians that also are working during the day. And it's the same EMR, the same electronic medical record that we're going to open when you come in. And then it's also us you're going to see in the emergency department. So it's literally the exact same people working everywhere. And so it's really in our interest to try to keep people being seen where they need to be seen best. But having said that, in my region, we certainly see a lot of people who, especially post-COVID, I think, and as Toronto housing prices grow, that we're getting a lot of people moving out of Toronto and out of the GTA into our areas, and a lot of people coming who either don't have a family doctor at all or have one but that are over an hour and a half away or something like that. So we're definitely starting to see that. But again, it's a crazy day for us if our emerge wait is 6 hours, whereas in the cities you'll see 12 or 14-hour waits very routinely now. And when you do get through that emergency room, you're actually seeing a family doctor. It's not an emerge specialist. So it is kind of, rural Canada secretly actually has a pretty decent, weirdly good access in some ways. I'm sure it does not feel like that to all patients because you don't necessarily get your choice of who you're seeing, right? Like it's all us all the time. There's nowhere else to go. So if you don't like any of us, you're out of luck, to be honest, because there aren't 15 other of us waiting around to see people. But we do actually provide, I think, fairly great access compared to what it could be like. Yeah.
Yeah, great. Thank you both. For next question, we'll start with Sarah this time. We talked about travel a little bit in the beginning about the general challenges of access to healthcare in rural remote communities. So I'd like to ask, what is the average travel time for patients in your community to access hospital-based or core service care?
Yeah, so my answer will be very different than Lindsay, but for us, it's we have our hospital, which is right. We have a big hall. We do, a lot of deliveries every year. We offer a lot of inpatient services, general surgery, internal medicine, which is right in our town. Most people, and there's 2 other hospitals in my region, which are also excellent. So most people, I would say, live within 45 minutes to an hour of those hospitals. To get to sort of the next level up, where there would be a higher level nursery for babies, more options of surgery, and a hospice, that can be anywhere, depending on where you are in the region, from 1 to 2 hours. And then to get to the big centers, which for us would be London or Hamilton or Toronto, is, depending again on where you are, is 2 to 3 hours. So specifically for hospice care for our region, we're definitely looking at usually at least on a map, it would be half an hour, but depending on from the Fergus Hospital, but depending on where you are in the region, that could be anywhere from half an hour up to 2 hours. And then of course you have the time of year. So, it can be extremely snowy and icy and goodness knows what else. And that really changes our commute time as well. And there's no public transportation. So you're completely dependent on someone being able to drive you.
Yeah, thank you for that. Same question to you, Lindsay. The average travel time for anyone in your community to be able to access core service or hospital-based care?
We have a 6-bed inpatient hospital with emergency department right in our town. So for anybody who lives right here, it's about 2 minutes. But our catchment area goes 7 hours down towards Fort Nelson, 5 hours towards Dease Lake, and 5 hours towards Whitehorse. So could be quite anybody basically 2 hours within Whitehorse heads that way versus to see us. Although since we have better access and quicker emergencies, sometimes people are coming all this way. We have a lot of patients who live in the bush up here as well. So it's always, and they live remotely off with no access to phone unless they have satellite. So we do have basic care here. However, we have no specialists. We only have family doctors here. Anybody who is pregnant at 38 weeks gets sent to Whitehorse to convalesce for 2 weeks or however long it takes for their delivery, because we just aren't set up to do deliveries, nor do we have enough volume to keep our skills up in the community here. That being said, we do emergency deliveries only, including the specialist access. In Whitehorse, we do have pediatricians, general surgeons. We don't have in-house internal medicine, unfortunately. We do have obstetrics, orthopedics, but that is 4.5, 5 hours away from here. Again, depending on the roads in the wintertime. It's not a safe highway either. It's completely covered in ice, lots of wildlife, and dark most of the season up here as well. So we do have a shuttle that runs 3 times a week, Monday, Wednesday, Friday, to the city that patients can take. Otherwise, everything else out. If emergent is medevac out, our ambulance can't go by ground because it takes them out of the community. We have one for the entire day. So it is quite a ways. And then I said, otherwise, it's to major things like anybody who's having a stroke or heart attack or needs urgent cardiac surgery or anything has to go all the way to Vancouver. So we do have an airport in town and we do fixed wing evacuation. So depending on what they need, we'll choose either Whitehorse or Vancouver, which is 2.5, 3-hour flight at least. So.
Wow. All right, thank you so much. Next question, and we'll start with Lindsay this time. And you've touched a little bit on the different types of travel, but let's say for patients that are unable to attend appointments in person or see care in person due to their condition, do you have accommodation to support their needs?
Basically, since COVID, the ability to use virtual medicine has really exploded. And that's probably the best thing that could have happened for rural and remote communities, to have that access to specialists. So we have a telehealth capabilities right in the hospitals where we'll bring the patient in with a camera and the specialist will interview them. And then it allows us to be in the room, or nursing or family as well, to be part of that appointments. So that has really improved things. And that's often because we don't actually have any other allied health services in this community, either like physiotherapy, occupational therapy. They maybe visit twice a year. And so for those things, we can use the telehealth access. And a lot of it now, not even just the telehealth with the video, a lot of our appointments, most of them are actually over the phone for specialists. So especially if I refer someone to a general surgeon to get a colonoscopy for, say, they'll do the original consult over the phone only. So the patient doesn't have to travel all the way there and back just for a quick consult. They just have to go for the actual procedure. So that's really improved access for our community members.
Absolutely. Wonderful. Sarah, same question. For patients unable to attend appointments in person, do you have any accommodations available to support their needs?
Yeah, so very similar. We certainly, we'll try to accommodate with video or phone consult to like talks with us. And then we'll do home visits as well. And as needed, I'm sure you guys do too. And then a lot of our specialists, again, mostly during COVID, sort of figured out that they could also do a lot of their consultations by distance as well. The way the billing is structured in Ontario, they unfortunately redid a lot of it so that it's not always as easy now for patients to access that, but we do our best to figure it out. We can also do e-consults, which are kind of these very secure email type of consults, and get quite a bit of information back that way, and then just manage things ourselves without patients actually having to leave the community to be seen by people. So that's really helpful as well.
All right, thank you both for that. And before we move on, I just wanted to touch on home visits. For both of you, or for perhaps your colleagues in the community, is there, a maximum travel distance, or sort of a boundary beyond which you would not, provide a home visit, just to kind of give a sense of how close or how far someone can be to your community before home visits no longer become an option? I'm just curious.
Go ahead.
Yes, no, sorry, I was gonna say, I have traveled up to about half an hour, but like as soon as I leave town here, I lose cell reception immediately. And so if I have an emergency or something happens, then it's also putting myself at danger. And so I usually am limited to the town area, the communities, especially the First Nations communities around here. And we have a band, because we're right on the BC border, or a reserve just south of here. And so we go there, even though no access because there's still people around, but it's so remote around here that I won't leave these areas where if I needed help or backup, I wouldn't be able to access it.
Absolutely. Sarah, anything to
Yeah.
add before we move on?
I mean, probably that kind of half-hour idea. I've certainly gone further if needed for special consults, like for medically assisted death consults. And we do have a palliative care family doctor who will cover the whole region. So he'll go whatever that is, probably 3 hours from tip to tip. And we have teams of like palliative care nurses who will travel and do those distances as well. So we can always talk to physicians that are in closer to those people to get them seen and stuff like that. So we can kind of work together for that usually.
All right.
So I did travel quite a way. I used to in Northern Alberta travel to do MAID assessments. If they didn't have an assessor in the communities, I used to do that, but it's a little bit different here because we're too remote.
Yeah, absolutely. All right. Next question. We're going to move on now from healthcare access specifically to end of life care. And we've touched a little bit on things like palliative and hospice care, but I'd like to dig a little bit deeper. And we'll start with perhaps Lindsay this time. Lindsay, what kinds of palliative and hospice care are available in your community? Are there any community or home-based programs?
Yeah, so we do a lot of our palliative care at the hospital. We have one specific room in our hospital we've kind of designated as palliative. It's much larger. We'd have families come and stay there. And so we do a lot of home visits as well in the community. We have a very excellent home care nurse who will come with us to all of these appointments, and often we have to go see them daily or quite close at the end. Our closest hospice is in Whitehorse. So it's a long ways away, so we don't typically usually use it unless we really need the tertiary backup. It's not even tertiary care, but like specialist backup. So our trained palliative specialists, their GP and palliative are in, two of them in Whitehorse. And so we have access to them. So mostly we do virtual consults for us to be able to keep patients in the community here.
All right, thank you. And Sarah, same question. What kinds of palliative and hospice care are available in your community?
Yeah, so we kind of lucked out here and have a really solid group of palliative care provide people who work allied healthcare, actually, who work out of our family health team, which is this Ontario thing that is funded. So I don't have to pay for it. There's a nurse and a social worker and some support staff, and they'll actually either see people at a clinic with us or they'll do home visits. They're supported by that palliative care family doctor I talked about, and then lots of us do a lot of our own palliative care as well. So we're pretty lucky that way. It's just the way that we chose to use that funding from the province instead of using it for diabetes, or I mean, we have some of those things too, but we sort of really took on palliative as an interest. Hospices, I mean, we're certainly not as far as Whitehorse, but we're not close to a hospice as much as we would like to be anyway. We're, as I say, within that sort of half hour to 2 to 3 hours, especially in winter. And so we are working to establish a local hospice that would be part of our actual community. And the other problem with us is our official palliative beds in our county are either at that hospice or are at, there's another sort of respite or convalescent care hospital, but neither of those places offer medically assisted death as an option. So our hospice hospice would offer that, because we do find that's quite a barrier. So we end up keeping people either at home if that's their choice, which is great, and I think we do a very good job of supporting that, or we'll end up keeping them in hospital. And similar, we have designated areas in the hospitals, and we'll use those versus the people transferring to hospice. Some people still choose to go to hospice, especially if they have family down there or they're more able to travel, but a lot of people will just choose to palliate in our hospital beds.
Thank you so much. And just before we move on to the next question, I'm just curious from both of your perspectives, for patients that are approaching end of life, what's the sort of proportion of folks that wish to die at home or to die in hospital or hospice?
For us, a lot of patients really want to die at home, but they don't necessarily understand what that means, or nor the families that the level of care that patients actually may need. And unfortunately, because we have one home care nurse for our entire community, we can't always provide the same level that they would be able to have should they have a team, a dedicated palliative team be able to come, including infusions of medications and stuff that we can't necessarily always do. Here, we're limited by we have a local dispensary, but we don't have a pharmacist. I'm the pharmacist here too, right? So we're really limited by those options. We do have, I would say, majority of our patients do come into hospital, especially right at the very end, if we can't get good control of their symptoms at home. We would love to be able to do as much as we can at home, and we really do try if that's their wishes. We just lost our office manager 2 weeks ago, had a very successful home death. I wasn't involved in her care, but sorry.
No, that's okay.
Yeah, because it's very new.
Yeah.
So it is possible. We do it, and we have a great team that will go out and do everything they can.
Yeah.
I apologize.
No, that's okay. That's okay. Take a moment. I'm so glad
I'm
to
so
hear that
sorry,
she had a
Lindsay. That's so
positive.
hard. Yeah. We sit around 50-50 in terms of patients who die at home versus who die in hospital. But we know that the choice there is not always realistic, just because, as Lindsay said, it's very challenging to do a home death, especially if the resources aren't in place. The funding for home care has dropped tremendously in the last couple of years. And sometimes logistically, if it's an elderly couple without a lot of support around, families don't always realize how much it takes to actually die successfully at home. Or if there's young children in the house as well, if it's a younger patient, that can be very challenging. So those are patients that might benefit from hospice if that was an option. And so we end up bringing them into hospital, even if it's not quite their first choice.
Thank you for that both.
Yeah.
Let's go to next question here. Are there any resources, and we'll start with Sarah, my apologies. Are there any strategies, or excuse me, are there any resources you'd recommend for people experiencing grief in your community?
So I think in our community, it is mostly through the family health team, like I talked about. There is also a lot of programs that our local hospices do offer, although they tend to be more centered around where the hospices actually are. There are some programs they'll offer in our region too, but they're a bit more limited. And then there are certainly, I have online things that I'll hand out often, accessing actually through Dying with Dignity or other similar organizations if people are looking for that kind of online support. I think that's just been burgeoning in the last few years. So those are all quite helpful, as well as their family doctors. I think because we're so embedded in their families, we're grieving alongside them. Honestly, I'm taking care of 3 generations at once, so I'm seeing everybody, and we all kind of carry that along together.
Yeah, thank you for that. Lindsay?
Very similar to here. We have a mental wellness hub that we'll send people to for grief counseling. We do a lot of it ourselves, like in the moment of. So everybody, because it's such a small community, if there's a death in the community, everybody knows, right? So all the vehicles are outside the emergency department, and so we will even do a lot of it right out of the emergency. And there's been some specific cases in town when there's been a particularly large amount of deaths that they'll bring in more specific grief counselors for people, especially if it's been trauma related and stuff as well. So, but besides that, a lot of virtual access because just the nature of where we are.
Yeah, of course. All right, thank you both. Next question. Are there any strategies or approaches that you apply to provide culturally appropriate care to patients? And Lindsay, we'll start with you this time.
I work in a predominantly First Nations community, and this has been a big push for us to promote indigenization of our hospital. And so there's been some wonderful introduction of new practices. We have a brand new healing room within our hospital, which is a safe place for families, especially end-of-life care here for the First Nations. People move into the hospital. They sleep on the floors. They sleep on benches. We give them all the beds that we have. And we provide food, drinks, coffee for the family. We have a dedicated First Nations liaison health worker who's just done phenomenal things, bringing in traditional teas, and we're now bringing in traditional meat off the land. So for people who, their last meals, they can have more of the traditional foods that they want. If they want smudging, they'll arrange to turn off the fire alarms
alarm.
and so that sprinklers don't go everywhere. So we're really trying to focus on more of the traditional sides of things and support and not just with indigenization, but any kind of spirituality that any patient wants. We do try to really focus on that, but a lot of it recently has been about supporting our community that we have here so that they feel that the hospital can be a safe place. We do have a residential school that was only 20 minutes away here. So we have a lot of people who don't trust institutions in our community. And so we're working really hard to kind of change that.
Absolutely. Thank you for that. And Sarah, same question. Are there any strategies or resources that you can offer to provide culturally appropriate care?
Yeah, Lindsay, were you going to say something else? I felt like, no?
Oh, no, I was just going to say
Okay.
that. Sorry. Well, I was going to say that all of the physicians here actually have to do a First Nations 101 course here as well now through Yukon University in order to have the license, so that we are more aware as well. So sorry about that.
No, that's
Apologies.
great. Actually, that's very yeah. I think at the moment, honestly, we take it's case by case. So I think we will bend over backwards when we realize there's a cultural issue, or cultural issues is a crazy way to put it, but you know what I mean. When there's issues that a family, we try to always take what a family and a patient is looking for and what respectful care is for them. But currently, I would say it's a bit on a case by case basis. But I think as this hospice we've been working on, it's becoming a really kind of an amazing community empowering project, to be honest, in a way that I didn't realize it would become. And I think it's allowing us to really step back and say, okay, like we're building this whole new thing. We can do it from scratch. What are we going to do to really make this work? And people are really, liaisoning with lots of different, again, as Toronto empties, we're seeing cultural people who have different backgrounds, have not grown up in Canada. Stats. I know that's interesting. Like the government will say, oh, you need this many hospice beds per population, but what is that even based on? How do we're really finding it's a build it and they will come situation. So I think that's been very exciting to really put that out there as something in our community, perhaps offering even respite beds as well for patients who are palliating at home, but their families need some respite. And just to see people really kind of figuring out, oh yeah, that's a great thing. Wow, this could really become Okay, well, so how about we put a garden? What if we, grew the food for it? What if we connected it to the Indigenous Healing Circle that's over there? What if it's really been quite amazing to see people come together in a conversations, not just around palliative care, sorry, not just around hospice, but around palliative care in general, around medically assisted death in general, just around death in general, actually, because I think we, as we know, as a society, we don't tend to go there in conversations as often. I think I do a lot of obstetrical care as well, and we talk way more about birth than we do about death. And so it's really fascinating for me to see that starting to come to light. I would actually put that as the big innovation. I mean, there's lots of structural changes we're working on and medications and learning and all this stuff, but I think the societal shift is really key right now, that we're actually discussing these issues and people are admitting, yeah, okay, we're all going to die someday. What do we actually want that to look like? And what do we want to have that look like as a community? So I find that really exciting.
I find it exciting too. I can't wait to hear once that hospice is on the ground. Lindsay, same question to you. Any new innovations that you'd like to highlight, and if what impact has that had on the community?
So we're trying to do more outreach within the community here. So we actually one day a month are going to our senior center and just doing home visits there. We do home visits every day, like as patients need it, but we're actually running a clinic right out of our little senior center that we have. We're going to be doing that out of the high school as well. We don't have a long-term care in our community. This is the biggest issue that we're facing right now. So, and we have a very elderly population. So most of our elders, once they do need level of long-term care, they have to move to Whitehorse, and that includes breaking up families, moving people away from all of their friends, the resources, everything that they know. So that's the biggest thing that we're trying to address right now. We were supposed to have 2 of our inpatient hospital beds changed into long-term care beds for now. Unfortunately, we're having some barriers with that, with being able to hire staff. As we know, there's a human health resource crisis across the country. And so finding staff to work here has been very difficult. So we're coming up with some more creative ways and bringing more Meals on Wheels and stuff to the community so that we can try to keep our seniors in the community and for as long as possible. So I had a meeting with our Deputy Minister of Continuing Care last week. And so there is some promise there, but we have a lot of work to do. And we won't be getting a long-term care facility here for a while. It's basically what I've been told, unfortunately. And that's really what the town wants. But we need to kind of work to bridge it in the meantime until we can get one.
Yeah, absolutely. Wow. Thank you both. All right. So for next question here, just before we move on, one of our audience members was just curious. Sarah, you'd mentioned a respite bed. Could you go into a little bit about what that means or how it's different from perhaps just receiving end-of-life care in hospital, for example?
Sure. So we generally think of, I guess, there's different ways to talk about respite beds, but in the context that I was meaning, and I'm meaning it would be in terms of where, say, someone is what we call not quite palliative, so they're end of life or approaching, where they're needing quite a bit of care at home. Sometimes that's for physical reasons, and sometimes that's for cognitive reasons. So a dementia that's progressing that just requires a lot of care that way. And so respite bed would be something where it might be a day program, or more common, what I would be more involved in would be an overnight option where a family could be confident that their loved one is well taken care of by people who understand, who will adapt to what that person is used to at home as much as possible, but they're out of the home for a night or for several nights, even a week or longer, to give the family some respite. So it's actually respite for the family, not for the patient, I suppose. And to allow them to just reconvene themselves, maybe get away for a holiday, maybe have some, if they're working on we had someone who was trying to finish a PhD thesis, stuff like that, like just anything where the care is just becoming very intense, and there's, it's very challenging in those situations to bring in outside help. Often it's expensive if you're trying to hire privately, and you may in a rural area there just isn't access to private agencies like that anyway, probably. And it's not something back in the day, to be honest, our small rural hospitals used to sort of offer this under the table a bit, but these days it's our hospitals are so packed with acute ill patients that that's rarely an option now that we would be able to offer that. So that type of thing. Yeah.
We do offer that here. It's quite common for us. One of my inpatients right now,
Yeah.
her daughter's away on getting medical treatment out of province. So there was nobody to care for her, and she just isn't safe at home alone. So it's very common for us to do that here. And luckily we still have space most of the time. That being said, sometimes we have to last minute, if we are overloaded with medical patients, we have to send our respites home early, but we have a lot of planned respites here to give family that break.
Yeah, and honestly, that's been an enormous change for us in the last probably 5 to 6 years, is where even as a rural hospital, we'll routinely now have 5 to 8 patients that are admitted, but are still in the emergency department, which is just unheard of in rural Ontario. That's not something we've ever seen before, but it's just a reality. So to bring somebody in who's not acute is very, very challenging these days, unfortunately. Yeah.
Wow. All right. Thank you so much to that audience member who asked that question. And thanks for the clarification, Dr. Gower and Dr. Campbell. For next question, and we've heard some of this through the answers that you provided and also with your biography. So I'll start maybe first with Lindsay. Have you ever provided care to a patient that considered or pursued a request for medical assistance in dying? And maybe you can talk about the level of care your involvement with made.
So I'm about as involved as it gets with MAID. I did the first one in the Yukon, and then did some of the very first ones in the area I was working in Alberta. There was nobody else doing it at the time when it first started. And so I had to figure it out, and kind of helped with the process of making a little bit of a program. And one of the areas I worked in Alberta was a very spiritual town, very religious. And so nobody wanted to be involved. So I would have to actually drive into Edmonton to find a pharmacist to get me the meds and drive back like a 2-hour round trip, because
Wow.
the pharmacist locally didn't feel comfortable dispensing the medications. And so there's after I started doing that, I just kind of got grandfathered into the MAID program because they knew I was doing so many of them in our local hospice for anybody who wanted it. And as a hospice, that the MAID program asked would I be willing to help them because they didn't have enough assessors nor people to provide at home. So then I started traveling around Edmonton and Northern Alberta region doing the assessments. And then in the Yukon here in my town in Watson Lake, I'm the only one who provides right now. And so it's a barrier for our patients as well, as if I'm not here, then they don't have access. Unfortunately, they do have people who assess, but so they kind of have to plan it around my schedule when I am in town, which is really unfortunate. But yeah, so I will do, and I'm willing to teach it as well. So I do have a colleague who is moving to our town, who will be willing to provide as well to increase. So yeah, I do the counseling behind it. I do the assessing and the providing, and then the grief counseling for family afterwards.
Incredible. Bit of a one-woman army you are.
No, but that it honestly it became that way, not because I chose to necessarily, but we had somebody in that was my inpatient here that requested, and there no other options available, and I wanted to be able to give this patient what they wanted. And it wasn't necessarily easy at first, but I've been able to provide a big resource for a lot of people that I'm very glad that I have been able to.
Absolutely. Sarah, same question. Your experience with any patients that have considered a requested MAID or your overall involvement with MAID?
Yeah, so when it first was becoming legal, we were paying close attention because we knew in our region that it would we would be just having to figure this out. Same thing. There was no real, it just kind of appeared. And, MAID's been funny because it's been really spearheaded in some ways. Well, I think physicians have always been involved and in spearheading it, but in terms of the execution or when it actually came into being, it's all been in legal channel. So we've always been sort of waiting, okay, what's the lawyer's decision, and can we just go ahead now, or what's going on? Like, it's, whereas, when I treat someone's cholesterol, I don't have to think about what the law is saying about that. So it's a little unique. It's been a little unique that way. It's really the only thing in my practice that is like that at the moment. But anyway, so once, because the drugs were already, it wasn't that we were waiting for drugs to be approved, or it was literally just waiting for the legality to come through. So, again, at our small hospital, rural, we're like, okay, well, who's going to take this on? So a little group of us sort of figured it out and just started as patients requested it. And there were some who were kind of waiting for it to be approved. And so there, I think, like many communities, there was a little burst at the beginning of people who had been waiting. And so we just kind of talked it through and figured it out. We were lucky that we had, our hospital wasn't, no one, I would say, was like, yes, we definitely want to be at the forefront of this, and let's really, advertise this as a thing. But there were very few barriers. We were able to just kind of forge ahead and very carefully make sure that the nurses who were on the floor that day were happy with it, or that the home care person delivering the medications that day was okay with it. And we just kind of quietly started going ahead with it without too much fanfare. And interestingly, for rural community, which I think you would think would be more traditional and, might kind of freak out, there's a farming thing too, right? Where people are like so many people have said to me, well, I wouldn't treat my horse like this. So, I kind of get it. I euthanize my dog when like there's kind of that concept. And I think death in a rural, we are very rural, very agricultural still. And, death is there. It's of animals, and it's a bit, but people really, and people remember how their grandmas died. They remember watching an uncle, that really suffered for months and months, and they don't want that to happen. And so it's actually been quite interesting that at the beginning we weren't undercover, but we weren't exactly out and about either. But gradually it's definitely become much more of the fabric. And a lot of our local family doctors now will do their own assessments, or, have a lot more in-depth knowledge of what the deal is. If they're not comfortable, they'll refer right away. We're quite lucky that way. And again, because it's the same people that are around, we're in the hospital, we're in the walk-in clinic, so we kind of see people. So even if I run into someone and I'm like, oh, maybe your family doctor hasn't quite offered this yet, maybe I'll just mention it because I'm seeing you at this moment. And so I feel like people have pretty decent access. In Ontario, there's a central number that you can call as well for referrals. So I think there's maybe fewer barriers than there might be in a bigger city where you're a bit stuck with whoever your local person is. You might have language barriers or different barriers that way, but it's actually been a pretty straightforward experience here, I have to say. And I'll just say too, we've been very open about the fact that we will be offering MAID as an option at our hospice. We had this big community event last fall, which we had like 600 people come out to it. It was enormous. It was amazing. And we had some protesters, but it was a very small number. They were centered around MAID only, not around the hospice, and very respectful, very, just didn't interfere with anything. And that's fine. I have no problem with that concept. And in fact, we have local hospices who don't allow MAID. So it's actually kind of easy. You can easily go to a facility or support financially if a facility that doesn't offer it. But we're going to, and people have been our local government, has been extremely supportive of us. And we've been open about that from the beginning. So it's nice to see that.
Yeah, absolutely. Lindsay, I'm not sure if you wanted to add something on. I saw you perhaps want to jump in.
My computer just froze. So.
Oh, okay.
Oh.
Not a problem. All right. For next question, what end of life care or programs are easily accessible in your community, and which ones are not? And Lindsay, we'll start with you this time.
So in hospital and home palliative visits are easily accessible because of our access to family doctors doing it. And tertiary care is not accessible, right? It involves being transported to Whitehorse. And that's including senior oncologists and stuff as well. If you need that specialty care going back and forth, it's not as easily accessible. We are limited with our physiotherapy, our occupational therapy, our social work, our mental health resources, all of the allied health that we wish we had more access to, home support workers as well. We have one healthcare nurse, home care nurse, and right now we have no home support workers that are on right now. So it's very difficult for somebody at home who just need, the once a week bath or need the medication assistance and stuff. We just don't have anybody that is able to provide that. And so that's why some people do end up having to come into hospital to have that. But we do provide excellent end of life care as inpatient. And then, if we're able to, with home visits as well.
Absolutely. Sarah, same question.
Yeah, so I think we're very good at offering very solid medical palliative care, and I think we're quite good at a lot of the psychosocial pieces around it, but we just don't have the resources that I see in some of the bigger centers in terms of an art therapy group or a Reiki person coming in, or like all that kind of things. That I know there's been some comments around the death doulas, or like we just don't necessarily have those resources available. So as family doctors, as our nurses, our mental health therapists, we kind of end up filling in those gaps for sure. And I think we're quite skilled at it. But I would say those are definitely some things we can't offer locally. And then in terms of, that tertiary palliative care where, maybe someone could probably use some radiation, some palliative radiation, that's tricky to get. It's not as far as it would be for Lindsay, but it's still going to be an hour by land ambulance to get somebody to do a 10-minute a day radiation. That might actually make them more comfortable, but it's really difficult to organize or impractical to get someone to do that. So they choose to palliate locally instead without that access, that type of thing, that I think would be available in a bigger center. And we'll always try to offer it, but it's just, we know it's with a grain of salt that really, if you were in downtown Kitchener or Toronto, you would have access to that, and that we can't really offer.
Yeah. All
Yeah,
right.
our patients have to go to Vancouver for that. So
Oh my gosh,
and
yeah.
they have to, or Prince George, but it's usually Vancouver. So
Yeah.
that involves and family going down with them, staying, and they'll do 3 days a week for 3 weeks. And so it's a really big deal to be able to get that here.
Yeah.
Yeah, it's substantial. All right. Thank you both so much. That ends the formal interview part of today's session. We've been receiving quite a few audience questions, so thank you so much to those who are watching and have submitted your questions. And let's take a look here at what we can tackle today. This is a great question from an audience member, and either speaker, feel free to jump in. This audience member asks, have you encountered any challenges with supporting people who speak languages besides English while practicing in your area? And how are these challenges overcome?
We actually have this little iPad that has a translator, that it's an app that we connect to in whatever language, and it'll dial in, and you can either choose video or not, and it'll have a medical translator be on this little mobile iPad that we take everywhere on the stand, and we can do it with video so that we can basically make sure that they're understanding what we're saying and we're understanding what they're saying. Sometimes you use family members, but sometimes we prefer to have somebody who's medically trained to be able to make sure that these points are getting across. So that's something that our hospital system uses.
Yeah, similar. So and I actually run into this quite a bit in obstetrics. And so we'll use, sometimes I'll just use Google Translate. Actually, it's quite good for a lot of languages. It's actually like bizarrely good and improving. And then we also have access to interpreters, and some are actually medical interpreters, which are great because they can sort of interpret the nuance of what's going on rather than just trying to translate the word for word piece. So yeah, we have a quite a large Mennonite population that not many don't speak English or a high level English as a first language, especially the women. And so we'll utilize those guys a lot. And again, as people are coming in from other areas, we're seeing lots of different languages. Large immigrant populations are coming into the area. So that's what we usually try to do. Yeah, and it's pretty successful. With same thing, like family members will show up, but often it's the kids, and it's just like not really appropriate to be using them, and especially when it's very private information, as well as you're trying to explain, like, and then I will check your cervix, and the 8-year-old's like, it's just like, okay, I need something official here. This is not going to go well.
Yeah. Wow. All right. Thank you, audience member. For next question here, this audience member asks, with limited resources, even in urban areas, what can I do to ensure proper end-of-life care if I want to die at home?
Yeah, so it's interesting. I am on a few different discussion groups of other physicians, and it's actually, I'm going to say, it's a bit shocking to me how often this question comes up, even among physicians, of saying, my person is in such and such a place. Sometimes it's a small place, sometimes it's a medium or a big place, and I just can't figure out they're in pain and they're supposed to be under palliative care, but no one's really assessing them, and what should I do? And I think you really do have to advocate for yourself, I think, wherever you are. And I'm so sorry it has to be like that. I wish it was a more widespread, broad system. And I think we work really hard in my region to make sure that people don't fall between the cracks, although I'm sure people do. But, it's certainly, I think that the CCAC is a great place, which is now in Ontario. Whatever your home care is, I would say those are really great people to reach out to. There's a pretty good accountability there, where someone will at least hopefully answer the phone during weekday hours and get you hooked up. And that's in Ontario, that can be a self-referral, which many people don't realize. You don't have to go through a physician for that. But it's really going to depend on your region and what the options are. And even showing up to your emergency room may not work, because if these days, even in my little emergency room, we've got people who are coming to fill in from outside the region because we can't fill our own shifts anymore. And so you get someone that's, from Toronto who's showing up to do my emergency room, which is fabulous. Thank goodness they're there, but they don't know the local system. They have no idea. So okay, well, maybe a nurse is working that knows the system. Well, now we've got agency nurses who aren't local either. So the whole thing is kind of falling apart at the seams a bit. And you do really have to advocate for yourself. And I would not hesitate to do that and really keep pushing until you find once you find the right person, I think you're set. Then you're kind of in, and that person will hopefully be able to navigate the local system for you. But it can be very tricky. I really hear this all the time. And I feel like I'm getting personally called on by friends across the country way more than I would have a couple of years ago to say, hey, sorry to bug you, but so-and-so, my uncle is having this problem. What can you do? Does he have to go to emerge? It's going to be a 15-hour wait. What would you guys suggest? My husband's also a family doctor who works emerge. And so we're just getting called on so much more by our own social circles and family members than we would have a couple of years ago. And I think that really indicates how stretched and kind of, tricky access really is right now. And that's not just a rural problem by far.
Yeah, absolutely.
My biggest recommendation would be to make sure that you have these conversations with your family ahead of time. So this is the biggest thing, that people don't have these conversations until they're at very end of life, and you may be confused and you may not be able to make those decisions for yourself necessarily. And so it's really important that even prior to a palliative diagnosis or anything, to really make sure that your family understands your wishes, to have a personal directive, an advance directive about what medical things that you would want done or not want done, to have that power of attorney as well, which means that financially, say you're in the hospital and you have bills that need to be paid, that there's somebody who has access to your fundings to be able to do that. Those are very important conversations that should not be in your final days. And that helps you to navigate the system a little bit better, especially if you have a family doctor. They are a wonderful resource. And I understand that so many people in Canada don't have that, but that should be your go-to point, to have that conversation with your family doctor. And then they are able to tell you what resources are available in your area. And I agree, home care is one of them. Some governments have this extra funding that they'll give, so you can hire somebody who's outside of the healthcare system. So a personal healthcare worker and kind of a private system to come in if you don't have access to home care. But it really depends on where you are. And so having that quarterback, as Dr. Gower said, is really important. And sometimes, usually it's your family doctor, but yeah.
Yeah, absolutely. And certainly setting that up in advance and having those conversations in advance is half the battle itself. So thank you both. All right, for next question here, let's see. So this audience member asks, our rural doctor, who was the only one in the area that could provide palliative care, did not share with us that they're unsupportive of medical assistance in dying. And so this audience member asks, are family doctors required to let us know their views on MAID? Now, obviously, we have Dr. Campbell is located in the Yukon, Dr. Gower is located in Ontario. Those are two different colleges that might have slightly different stipulations on referrals. So I'll have you sort of answer both from your perspectives. This audience member did not specify which province, so there's that caveat. But any thoughts from either of you?
I think this is actually national, this issue. And so if they do not provide MAID, they're supposed to be able to provide you with the information to be able to access it. So they don't have to take part. They have the ability to say, like, that I don't do this, but they have to give you access to it, or where you can get access, and you have to pursue that yourself. Is that do you agree, Dr. Gower, for your area?
100%. I think I can't imagine any college that wouldn't say that, and that goes for anything medical. If I don't believe in appendectomies and you come to me and you have appendicitis, I actually have to refer you to somebody who believes in appendectomies. That's just the law, actually. So yeah, it's definitely well beyond an ethical issue. That's just the way things should work. Whether they actually work like that, I totally get it. And that can be a huge barrier to many services in anywhere. But that is 100% how things should work. Yeah. But whether they have to disclose it, it's not so much that. I would say it's more that they have to refer. So they might not have, like, we don't have to say on, some biography somewhere that I support this, I support appendectomies, but not gallbladders. It's more that if you come to me with your gallbladder problem, I will refer you on regardless of what I feel about gallbladders.
All right, thank you so much. And thanks to that audience member. Next question. This audience member asks, is organ donation possible in remote or rural communities?
Yeah, so I don't know what you're like, Lindsay. It's probably a little different, but I'll speak because it's very exciting to us. We haven't, organ donation is something that we've really been encouraged to talk to patients about. And there's some really interesting things going on with it, where Trillium, which is the group in Ontario that does organ procurement, is really interested in speaking with potential donors while they're still alive, because they don't usually get to do that. And the consent is great because you're actually speaking to the potential donor, not just the family, and it's very much encouraged. And because they will bring a team with them, it is definitely possible to do in rural areas. Now, usually that's arranged ahead of time. It is always arranged ahead of time, I should say, but if at all possible, and because MAID is a planned procedure, that's how we roll. But it certainly can be done in hospitals where you traditionally would not have organ donation happening, because there is not the requirement to have people on life support in waiting for or whatever version of life support is needed for the organ donation that is being planned. And so we can definitely offer organ donation for patients who are choosing MAID in rural areas. Absolutely. It would either be done in a hospital, and then you would be transported to the operating room afterwards, because it's still done within an operating room. Things need to be sterile. Or the procedure could be done at home, and then the body transported to the operating room of our local hospital whenever is appropriate for the family. Yeah.
Right. Thank you, Sarah. And Lindsay?
It is available in the Yukon. It's difficult. In our site, we don't have surgeons. And so I actually haven't had a patient here request that. So it's not something I was just looking it up. I was like, and that's something that I absolutely should know. And I can't believe I don't, because I've signed my organ donor card and for sure want to donate mine. So yeah, I'm going to have to figure that out for our community. So thank you for bringing that forward for me, but it is available in the Yukon, and we do have surgeons in Whitehorse, so I would be consulting with them on that.
Great.
And
Thanks
just
for that,
and
audience
just to
member.
be clear, because I've been asked this, it's there's lots of organs that you think about,
Yeah.
kidneys or hearts, but the heart stops be beating or whatever. But there's skin, there's eyes, there's
Yeah.
bones, tissues. There's I think there's something like 98 different types of donations that can be procured from a very healthy body. And so certainly if there's cancer or if there's other issues, then that might limit, but there's still possibilities. And in someone who, MAID is often done, say for someone with a good example might be an ALS patient, so someone who is suffering from Lou Gehrig's disease, where a lot of their organs are actually extremely healthy still and quite amenable to transplant. Yeah, donation, I should say,
Absolutely.
not necessarily transplant, donation.
All right, perfect. Thanks to that audience member for that question. Next question here. This audience member is asking about what is a death doula, and another question here is a follow-up. Have you seen, either of you in your community, seen an increase in or make use of alternative palliative caregivers like death doulas? Have you ever had any experience with that in your communities or in the previous communities you've served?
So here we don't have any death doulas. My stepmom did train to become one, so I am aware of the process of something I learned about when I was working down in Alberta. So death doula is somebody who's kind of there, similar to a birth doula, is really as like your cheerleader and helping you navigate some of those difficult parts and some of those difficult conversations, that not just the medical side of things, but the spiritual, your relationships, and they can help you guide you through this process. They aren't necessarily a counselor. They aren't necessarily there for medical side things, but they're just there as a support and another voice to help you, because sometimes family members have a difficulty making these decisions and stuff as well. So it's somebody there as an extra encouragement and to help you, or for people who don't have anybody there at the end of life, so that you aren't potentially dying alone. Like I said, we don't have anything like that in our community. We don't have Reiki. We're very, very limited in what we have. And so the closest thing we have right now is our First Nations liaison worker. She kind of is doing a lot of these things for us. She's absolutely phenomenal. And so that's kind of the closest thing that we have to it. We do have our first person in the community training to become a birth doula, even though we don't do that many here. So, but it's an emerging area that I think is wonderful, absolutely wonderful. I know a lot of hospices do have this resource available.
Yeah, same. I haven't seen, we don't even have a lot of birth doulas locally, to be honest. And certainly funding is a big issue. I mean, you have to be able to afford it privately, I believe. I've never seen
Yeah.
one who's been publicly funded. So, and I think people just don't have the resources for that or don't consider it a priority, but that's certainly something we would be open to it if, yeah, for sure.
All right. Thank you, audience member, for that question. Let's see here. All right. This audience member asks, and it's posed towards both of you. This audience member asks, why did you choose to work in remote communities compared to the city, considering the lack of specialization as well as the distance for travel or otherwise
Um,
remoteness?
That's the whole point. No, I'm just kidding. It's so fun. No, but it is. Like I think, I don't know, I'll go first. I think that it's very fulfilling to be in a place where you kind of get to do a bit of everything. I think it suits most of our brains, I think, and most of our, it's kind of what we went into medicine to do, which was just to be helpful when it's needed. And, to be able to do an office in the morning and then go and run over and deliver a baby partway through the day. And then while I'm there I'll pop up and see a palliative inpatient, and the family member from Edmonton's arrived, so I'll sit and chat with them for a bit, and someone has come back into labor, back down I go, and then I'm finishing up some paperwork at the office and do a home visit on the way home. Like literally, I mean, some of my days are actually like that, and it's just really fun. And I think I get to do a lot of things that in a city I wouldn't really be able to do. And if system changes need to happen, like we just had a big meeting this morning about a debriefing of an obstetrical situation, and someone was like, yeah, we realized in this room when we were working on this baby that there's only one sharps container and it's way over in the corner and we need a second one, but occupational health said we couldn't put it there, so we're going to get one on wheels like the OR has, and then we can wheel it around the room, and boom, but I popped up before I came here and it's there. Like we already have that sharps container on wheels, and in a big hospital it would take months for that to happen. So it's very satisfying to just feel like you're actually in on things and helpful. It's just fun. I don't know. Yeah.
I like she said, I love the variety. I love the challenge. I'm constantly learning new things. They say that like the best you'll ever be in practice is at 9 years after you finish your training, which I'm on my way down now. But like, so I have to constantly keep up with new things, and I'm not just studying the left foot. I'm studying your entire body, and I have to. So it's really interesting, and I love the community aspect. That's the big thing for me. I realize now I hate traffic. Like I almost had a panic attack when I went to Costco in Edmonton, and I don't even have anxiety anymore. I'm just not. I like that I can drop my kids off at our phenomenal daycare and be at work within 2 minutes. If there's an issue, I love the flexibility of it as well. I get a longer time with my patients. The way I'm paid is different. So I spend 30 minutes with each of my patients, sometimes an hour, because I can, and I get to provide much better much better patient care than I would in a traditional fee-for-service system that I was working before. And that's a big thing for me, is so that I want to be able to know that I'm giving the best care that I can. And that was a huge draw for us to come here. We just had an outdoor curling bonspiel all weekend. We had a carnival last weekend with lots of things going on. So there's so many little things going on in the community. So you could know all your patients really well as well, and all their families. And that's a really big draw to it as well. I love it. I also love the outdoors. So I live here because I can go cross country skiing or downhill skiing or swimming or wakeboarding or kayaking or hiking. That's why I originally came to the Yukon. I came for a month to go hiking, and here I am 10 years later now. So that's actually all of the Yukon is from Ontario, pretty much, who come for the same reason. So there's a lot of challenges, but I think the benefits by far outweigh the risks. So.
All right. Wonderful. Thank you both so much for your time today. Unfortunately, we are out of time for today's webinar. I want to thank our speakers again for joining us, and thank you so much to our audience for staying with us, for submitting your questions. Just a reminder that this session is recorded. So for any folks that weren't able to attend in full or would like to review the session, it'll be recorded and published on our website shortly. So thanks again, everybody. I want to wish our speakers and our audience members and anybody else that'll be watching in future a wonderful afternoon, to take care and enjoy the weather wherever you might be. All right. Bye, Dr. Campbell. Bye, Dr. Gower.
Thank you.
Thank you so much.
Bye.